Hey everyone, so today we will be going over post-op complications. So what are post-op complications? These are problems that happen after surgery that are not supposed to happen. Alright, so today's lesson we will talk about what is a complication, what are signs and symptoms, how to prevent the complication, which are some patient education things, and what are some interventions that we're going to do if we run into this complication. So these are some common complications that we run into after surgery, and we will discuss each one of these. Alright, so let's start with first pneumonia atelectasis. So what is this? So pneumonia is an infection that affects one or both of your lungs, and atelectasis is a small or large area of the lung tissue which collapse. So this results in decreased exchange of gases within the lungs. So how does this patient look? They will be short of breath. They will have an increased respiratory rate. They will have an elevated temperature. They could have a productive cough, or they could complain of chest pain. So what are we going to educate our patient about this? We want to encourage our patients to deep breathe and cough. We want to have them use the ascending spirometer. We want to hydrate our patient in early ambulation as possible. And we want to reposition our patients every 1 to 2 hours. Alright, the next one is pulmonary embolism. So what is a pulmonary embolism? So it is a clot blocking the pulmonary artery, and it disrupts the blood flow in the lobes of the lungs. Alright, so how does this patient look? They will have sudden shortness of breath. They will complain of a sharp chest or upper abdominal pain. There will be cyanosis. They could have tachycardia, and you also could see a drop in blood pressure. So what are we going to do about pulmonary embolism? We're going to notify the doctor immediately. Once we see these signs and symptoms, we're going to administer oxygen and anticoagulants as prescribed. So make sure that you look over your anticoagulants such as heparin and Lovenox and Eliquis, medications like that we would give to patients who are experiencing pulmonary embolisms. Alright, so the next one is a hemorrhage. So a post-op hemorrhage, that is a loss of a large amount of blood externally or internally in a short amount of time. So what does this patient look like? So if they are bleeding externally, right, then we're able to see that, right? But internally, signs and symptoms that we will be able to see that the patient is bleeding on the inside is that the patient will complain of restlessness. They would have a weak and rapid pulse, hypotension. So remember shock, right? Tachycardia and hypotension. They could have tachypnea, and they will have a cool or clammy skin. So our intervention is going to be apply pressure to the site if they are bleeding externally, and then we want to notify our doctor and follow orders as prescribed. So if they are bleeding internally, meaning we can't see it, right? So that doctor would probably order them some fluids, but we would just follow orders as the doctor gives them. Alright, so the next complication is shock. So what is shock? It is a loss of circulatory fluid volume. So how does this patient look? They're going to look restless. They're going to have a weak and a rapid pulse. They're going to have hypotension, tachypnea, cool and clammy skin. So what are you going to do? You're going to monitor vitals, and you can elevate the legs to allow the blood to circulate back to the heart, but you don't want to do this in patients who have spinal anesthesia. And you want to notify the doctor and follow the orders that the doctor gives. Alright, thrombophlebitis. This is inflammation of the vein, often accompanied by a blood clot. So how does the patient look? They may complain of achiness in the legs. Their veins may be hard and tender to touch, and they may have a temperature. So what are we going to do? So we are going to notify the doctor and administer anticoagulants as prescribed. But what are some prevention or education for the patient is we want to put SCDs on the patient. We want to be doing passive range of motions if the patient is not on bed rest. We want to get that patient up as soon as possible. They could wear anti-embolic stockings, and then you want to teach the patients to not dangle their legs. So biggest thing is that this is inflammation of the vein, often accompanied by a blood clot. So if we can stop the prevention of a blood clot, then we could prevent thrombophlebitis. All right, so urinary retention. It is the patient holding on to urine, not being able to go to the restroom, or not emptying out their bladder. So what does the patient look like? They will have a distended bladder, the inability to void. They may complain of lower abdominal pain, and they could be restless. So what are we going to do? We're going to always assess, right? But we want to encourage ambulation and fluids. We can also pour water over the perineal area, or we can even just run water, and all that does all the psychological things, in your brain to make you think like, okay, I need to go to the restroom. Or you can catheterize the patient as ordered. So remember, you need an order to cath your patient. So when I say assess, that means do a bladder scan on your patient to see how much urine they are retaining. All right, so constipation. So remember, when we are under anesthesia paralyzes everything, right? So sometimes it takes the gut a while to wake up. So the patient may have constipation, which is abnormal and frequent passage of stool. So the patient may have abdominal distension, may complain of nausea, and the patient won't be having any bowel movements. All right, so what can we do about this? We want to encourage fluid intake, early ambulation, foods that's high in fibers, and then administer stool softeners and laxatives as ordered. So a paralytic ileus is when muscle contractions that move food through your intestines are temporarily paralyzed. So how does this patient look? They will be vomiting post-operatively. They will have abdominal distension. They will not have any bowel sounds or bowel movements or gas. So what are we going to do if a patient has a paralytic ileus? They're going to be on an NPO diet, right? Because if you don't have your muscles contraction that moves food throughout your intestines, why would we give that patient food? So they're going to be NPO, then you're going to insert an NG tube and maintain that as ordered, and then you're going to administer medications as ordered. So medications that would help with their signs and symptoms, like Zofran, maybe for nausea. So normally ileus resolves after you've had the NG tube in. All right, so the next complication is a wound infection. So this is an infection at the surgical site. So the patient may experience fever, chills. At the actual surgical site, they may have purulent drainage coming from it. It may be red, it may have some edema around it, and it may be also warm to touch. So what can we do? We want to make sure that we are maintaining asepsis, meaning we are being as clean as possible. Maintaining any patencies if they are drains. If we want to be emptying our drains like we should, we want to be flushing our drains if we have an order to, and we want to make sure that we're frequently assessing our sites. So we always want to make sure, especially the first couple of days after surgery, we always want to be looking at that site. So and then we would give antibiotics if ordered, or if we need to treat the fever, then we'll give Tylenol as ordered. All right, so now we have two different types of wound complications. So we have wound dehiscence and extravasation. So when we have wound dehiscence, that is the separation of your suture line. So that you can see it. Let me grab my little highlighter. You can see it over here where the sutures came apart, right? Which when you have extravasation, we see that the sutures has opened, and now the internal organs are coming through the incision. All right, so how does the patient look? The patient will have increased drainage, open wounds, and then with extravasation, you're going to be able to see that organ. So what are you going to do if you see that a patient has extravasation? So this is a medical emergency. So the biggest thing that you're going to do is that we're going to cover it with a moist normal saline gauze, and we're going to call the doctor ASAP. Do not try to put the organs back in. Do not put the organs back in. We're going to put the wet, moistened gauze over it, and then we're going to call the provider. Now, when dehiscence happens, you know, a little wound opening happens, what we just want to do is we want to call the surgeon and see what the surgeon wants to do. We could place a gauze over that as well and wait for the surgeon to come. But the biggest thing is to remember with disaster vexation that we are not going to try to put those organs back in. All right. So the biggest thing is prevention. So how can we prevent these things from happening? Because sometimes it's caused by a bunch of pressure that is on the surgical site. So we want to teach our patient to splint, which means is to take a pillow and hold it against their surgical site if they have to cough. We want to make sure they're not making any sudden movements and doing any type of weird exercises and all that kind of stuff. We want to make sure that they're not applying so much pressure on that surgical site.